So we see typical things that we're doing in the ICU changing from one study to another. Antiarrhythmics, I think, are an important lesson. This was a study done about 20 years ago showing that PVCs, which are something that most cardiologists and internists dealing with patients who had PVCs after an acute myocardial infarction were very, very concerned about. And physiologically speaking, it made sense to suppress these PVCs. And when they did the study, they found, in fact, that the active drug had a higher rate of death than those patients getting placebo. So there are some studies, maybe not the ones that Dr. Arrowsmith was going to be taking part in, but there are some studies where you might be better off in the placebo group than the treatment group. And finally, I couldn't help but not talk about steroids. So I'm still trying to figure out who the first person was who gave a septic or septic shock patient steroids. I have not been able to find that person, so if anyone knows about that person, please let me know. It doesn't make intuitive sense. But Bill Schumer showed in the Annals of Surgery in the 70s in a prospective study that patients who got steroids had a lower mortality than those patients who got placebo. We showed, in fact, there was no difference in a small one-center study in Miami, but there seemed to be a higher incidence of superinfections in those patients getting the steroids. And then there were two large multi-center trials, that of the VA cooperative study showing no significant differences, and then the Bone study, the Upjohn cooperative study, showing, in fact, a trend to a higher mortality in those patients getting steroids. Now, those were pharmacological doses of steroids, 30 milligrams per kilogram of methylprednisolone, the kinds of doses where some of the older physicians who I see in the crowd remember using. But then Jalali Anain came along and said, well, you know, patients who are in septic shock probably have relative adrenal insufficiency, and they don't need those mega doses of steroids, just a lower dose, 100 milligrams 3 times a day, or he gave 50 milligrams 4 times a day, 200 milligrams a day for 7 days should be enough. And in fact, in all patients, mostly driven by patients who were non-responders to ACTH, there was a higher survival in the patients getting steroids than those who did not. So once again, people were using steroids for patients with septic shock. This was a group of patients with severe septic shock who had systolic blood pressures less than 90 for more than an hour, what we thought was an atypical group. So in fact, we did the Cortica study, and Jalali Anain was one of the members of the steering committee, and in fact, we showed again that steroids did not improve survival. There were no differences, and there seemed to be an increased incidence of patients with superinfections, new sepsis, or septic shock. So you talk about different drugs and intensivists being schizophrenic. This sort of looks like a merry-go-round, the use of high doses, then stopping and starting and stopping. So what I've tried to do for you today is take you through some of the typical kinds of therapies we use in the ICU. I haven't been able to talk about all of them, about PA catheters, about sedation. I typically thought that most patients were better off being sedated, not knowing what was going on in the ICU, till some of Wes Eli's work showing, in fact, that that was not a good idea. So there are many, many things. I can't talk about all of them, and in fact, some of the members of the audience are some of the people who published some of the critical studies in this area. But as Jean-Daniel asked that we do go away with some type of takeaway message, I think we have to critically look at what we do on a daily basis in our ICU. Most of our clinical research studies started at the bedside, asking a question on rounds with our residents and nurses. I think we have to think twice about what we do. Right now, we typically accept the patient who's an ARDS and accept an FiO2 of less than 45% or maybe even 50%. Maybe that's too much oxygen. But I think if we think about the major problem in ICUs today and what they will be tomorrow, the major problem is clearly infections and resistant organisms. I think we have to seriously consider about all the things we do, but we have to really think about ways to improve things, the way we get physicians to wash their hands. The nurses are much better than physicians. But I think one of the things we looked at the European Society is one of the other research topics that came up was a way to look at the way we use antibiotics, and perhaps we don't have to use as many of the antibiotics that we do use, or the broad spectrum antibiotics, and if nothing else, perhaps stop the antibiotics a lot sooner, and that might be something to think about for the future. Thank you very much.